was walking with my donkey searching for you.
Cindy Davis, the force behind Dr. Eric Davis that keeps him straight and aligned, and has also put so much work and effort into this symposium since it started 7 years ago. Cindy has a vast knowledge of anesthesia. She's sedated and anesthetized over 6,000 animals in the field.
Who told you that?
I read that in your bio. And then she's also worked with about 700 donkeys out of that 6,000. Just a side note, the speaker's notes are in the overview on the HOVA app, so please utilize that so you can go back and get more information and share it with your practitioners. I'm not going to take any more time from Cindy. This is a wonderful treat to have her speak with us today. So thank you, Cindy.
Okay, thank you. My dog runs most of the anesthesia. He cleans ears while he's up there too. So that's his job, to make sure that I'm not screwing up while I'm working. So before I start talking about anesthesia, I wanted to tell you a little bit about myself because it does affect my perspective on anesthesia. If you don't know who you're listening to, you really don't know what to take seriously or not. So just so you know where I'm coming from, I've been working as a veterinary technician for 21 years. I have been a registered technician for 8 or 9. I worked at UC Davis at the hospital for 8 or 9 years, and I've done 17 years of field work with Eric. So we've worked in Guatemala, Nicaragua, Mexico, North and South Dakota, and California. We guesstimate that I've done about 6,000 total field anesthesias, and it's a guesstimate because for a fair number of years we worked for another program and I can't get those records, so I can't get accurate numbers for those times. But from 2012 to 2017, I do have good records. We averaged 450 animals a year during that time. Our largest year was almost 900, and 62 of those were donkeys. I have records for 237 donkeys in that 6-year period. And so from that, we conservatively extrapolate that I've anesthetized about 500 donkeys. And again, that's conservative, but I don't want to say I've done more than I have. This is a typical field clinic in Mexico where we will see, at this location, we'll probably see 370 animals. And on a really busy day, we'll anesthetize 36. We average in Mexico 170 castrations a year, and 40 of those every year are donkeys. Donkeys are not the majority of our practice, and this is basically my day job, is to anesthetize animals that I can't touch without a chute. So a lot of these, not a lot, but some of these animals have to be darted to get them in the chute. Some of them are darted after they come out of the chute. Some of these horses are out on really rough range, and it might take our clients 2 or 3 days to gather them and drive them into a corral. So these are my normal patients. Just so you know what my perspective is on anesthesia. Anyway, I mean, it's not the same as most people's practices. But despite that, I'm not an expert. I do not consider myself an expert on anything. I have done some anesthesias. I've worked with a particular subset of animals. And I'm just here to tell you, in my experience with these animals, this is what works for us anesthetically. So, I won't move on. We can't stay on that slide for forever. Okay, I was just going to touch on a couple of things from the literature before we talk about anesthesia. Donkeys metabolize a lot of anesthetics and sedatives differently than horses. Their hepatic metabolism is faster for things like phenylbutazone and guaifenesin, and they definitely metabolize ketamine faster. Mules are dosed with xylazine at a 50% higher dose than you would in a horse or a donkey. And they have an increased bioavailability and smaller apparent volume of distribution that can predispose donkeys to toxicity, so you have to be really careful with some drugs if you're increasing your doses or dosing more frequently. Different size donkey breeds metabolize sedatives and anesthetics differently. This really mirrors horses. It's not really surprising. Draft horses are not the same anesthetically as quarter horses, are not the same as thoroughbreds, are not the same as ponies. So this doesn't surprise me a bit. It really is just the same as in horses. Mammoth asses have a shorter half-life for some anesthetics, so you'll have to redose more often, but you have to do it carefully because you can get rough recoveries. And miniature donkeys generally need an increase in anesthetic dosages. Some of those differences are due to the fact that the hindgut of the donkey serves as a water reservoir similar to those that you would see in small ruminants, and that affects drug distribution and availability. And the conclusions from all the research that Tex Taylor and Nora Matthews did, effective field anesthesia can be challenging in donkeys. You can top off with intermittent boluses of xylazine and ketamine the same as you would in a horse, but the dosing interval is going to be more frequent. And you can use triple drip in donkeys, but you do have to change your protocol because donkeys are more sensitive to guaifenesin, so they're easier to overdose. So I'm going to start with the most basic protocol and build on it. This is the protocol that they teach you in school: 1 mg per kg of xylazine and 2 mg per kg of ketamine. Standard 1-2 punch. You can prolong your anesthesia a bit by adding butorphanol to the mix. Some people don't like butorphanol because there are some animals that will walk on it. It doesn't bother me to induce a walking animal. I have no problem with that. I like torb, particularly in the subset of animals that we work in. Benzodiazepines will also extend your anesthesia just a smidge. Those are traditionally given mixed in with your ketamine. I give mine straight after my xylazine, and I'll cover that in a minute why, but there's a whole bunch of reasons why. So you can maintain your anesthesia then with boluses of xylazine ketamine, mixed 1 part to 2 parts, dosed at 1/4 to 1/2 the original dose that was given. And again, you're going to have to top off more frequently in donkeys than you would in horses, in mules as well. You can also maintain your anesthesia with triple drip. But again, you have to use a different recipe, and this just is showing the difference between the horse recipe and the donkey mule recipe, which is not only a different proportion of xylazine to ketamine to guaifenesin, but it's also given your base rate for donkeys is slower than your base rate for horses. You have to adjust based on what your patient's doing regardless. You cannot just hang a bottle and go, okay, we're good. You have to monitor your patient and adjust your dosing. This isn't a protocol that I use. I honestly hate triple drip, but there are clinics that use nothing but triple drip and are very happy with the results that they get. I want my muscle relaxant on board at the start, and I want it off at the end. I want no muscle relaxation at the end of surgery when my patient needs to stand up. So that's one of the reasons I don't like the triple drip, because they're getting a muscle relaxant as long as they're getting the triple drip. But it is an acceptable protocol that people use. I just don't like it. And I tend to be slightly opinionated. And I'm not afraid to share my opinions most of the time. So why give your benzodiazepine right after your xylazine? I have a whole bunch of reasons why, in my experience, it works better. One is there is a rare but really scary excitation reaction that you can get in mules to xylazine. Doesn't happen very often. Nora Matthews has talked about it at this conference before. But if you give your benzodiazepine right after your xylazine, you're not going to see it. It's just not going to happen. Another is that we had a lot of experience in Mexico with xylazine causing neurologic episodes that are unsettling. And it's not fun to induce a twitchy animal. We always saw them in donkeys, not horses, even though it was the same bottle of xylazine. It varied from year to year where it happened. Some years it would happen in the mountains, and some years it would happen out of the mountains. I think it's related to something that they're eating at certain times of the year that the horses don't eat, because the donkeys are out foraging. But anyway, if I give my benzodiazepine right after my xylazine, I don't see that either. So that's my second reason. Also, particularly in the environment that we work in, it's pretty easy to rouse a patient from sedation. That's actually true in any environment. A sedated animal is not safe. If anyone tells you a sedated animal is safe, run. Just run. So giving the benzo right after my xylazine, again, will prevent a patient from rousing from sedation. And I like that as well. It also allows me to induce slightly early with less paddling or stiffness because you've got your benzo on board and it's your muscle relaxant. So if I feel the need to induce early, I can. Back to the basic protocol, 1 mg per kg of xylazine and 2 mg per kg of ketamine. In Plum, they used to have more doses than they have now. It's funny, over the years, when I first started doing this, the dose for thoroughbreds in Plum was 2.75 mg per kg, for ketamine, not 2 mg per kg. And then several issues ago, the ketamine was listed as 2.2 mg per kg for everybody except then there was a range of 2.2 to 2.75, and they had added, halflingers? Hackneys, one of those. And ponies, Arabs, and the thoroughbred was still in there. And now the Plum just reads, it doesn't even read 2.2 mg per kg anymore, it just reads 2. And there's no other category there. And I swear 2.75 for thoroughbreds, I wouldn't use any less, but anyway, I just think it would be silly. They're just gonna stand right up. Don't you want them asleep? Anyway, so basically, the point of this slide was to say, anesthesia is not cookbook. So the 1.1 mg per kg and the 2.2 mg per kg, that's all well and good, but this is what I give to students. Because it's a little more complicated than just 1.1 mg per kg and 2.2 mg per kg. There is so much that affects the choices you're going to make giving a patient a dose that just doesn't cover it, the numbers. Doing the math and giving that volume probably is going to result in an unsatisfactory anesthetic experience for your patient. Unless you're just dropping it to do its feet and it's a really quiet animal. I've had 2 patients where I could have given that. I remember both of them too, and it would have worked. So anyway, factors affecting anesthetic requirements include species. The mule is going to require the most anesthetics. The pony comes right after the mule. Then you get down to the burro, and below that is your horse. That's for an animal with the same level of socialization and training. So an animal that's in the same mental space, that is basically the order of your anesthetic requirements from most to least. The requirements are also going to be affected by patient temperament and level of training. That has a huge effect. Level of excitement and stimulation prior to sedation, and I think those 2 things are really closely linked. I would not underestimate how important those are. Breed, age, health status, patient positioning during surgery. I totally adjust what I'm inducing with based on whether or not an animal is going to be dorsal or lateral. And you can't forget that in different places, the quality of the anesthetic drugs is different. So in Mexico, I call the ketamine slow acting. I mean, it really, sometimes you wait and you wonder if your patient's going to fall down or not. And you look at your bottle and you go, no, that was ketamine. I know that was ketamine. So that makes a huge difference as well. There's nothing you can necessarily do about that. The drugs that are available. You can't buy something that's not there. So patient temperament and level of training. As an animal's level of training increases, in general, its anesthetic needs are going to decrease. And as its training decreases, its anesthetic needs are generally going to increase. Unless it's not a really excitable animal, because that's really related to how excited the patient is prior to sedation. So you do occasionally run into an animal that has no handling, but a lot of exposure to people, and who's not really afraid or excited, and you can quietly induce them without increasing your doses too much. So anyway, the level of excitement is a really critical factor in planning your anesthesia. Patient positioning during surgery. For dorsal recumbency, I increase my doses by 30% because all of the weight of their gut, their spleen, their liver is pushing on their heart and their lungs, and it's compromising their ability to move air, oxygen, and that affects their anesthetic needs more than a lot of people might realize. And that's true even if they're on just a slight hill. It doesn't have to be a huge incline, but if their head's slightly lower than their gut, your anesthetic dosing is affected. So the same horse in dorsal recumbency versus lateral recumbency, the anesthetic needs are lower in lateral recumbency. And for that reason, I am really pissy about people leaning on my patient while they're anesthetized because you totally affect the amount of anesthetics that I have to give to the patient. And as your anesthetic administration increases, you're compromising your patient's recovery potentially. So you also have to think about level of pain during and after surgery. Without adequate pain control during surgery, you have to use more anesthetics. If they're in pain after surgery, they're going to try and stand up before they're ready. And again, the quality of the anesthesia is very important. So you can't always control the length of your anesthesia, but you do need to realize that increased anesthetic dosing and time has the potential to decrease the quality of your recovery. So everyone needs to be ready before you get going to do their job, move ahead, don't waste any time. So assessment prior to anesthesia, for us, it's a little tough, but it's dependent on the level of training of your animal. It's dependent on the facilities you're working in, and it's dependent on what's going on around you. If there's too much going on around you and the animal's getting wound up, you're compromising your anesthesia. So the best thing you can do is just not get them excited. But even if you can't do a traditional physical exam, you can evaluate a whole lot of factors before you anesthetize your patient. You can see how fast they're breathing, you can get their rate, you can listen for noise, or watch for effort, you can see if there's nasal discharge, enlarged lymph nodes, if their eyes are bright or dull, or crusty, if they're cloudy or they have discharge, and you can see if their hair coat is healthy, appropriate for season, and you can evaluate their mentation. We generally don't take a temperature before anesthesia, clearly not in the chute. But even in a patient out of the chute, if we think it's going to excite the patient, we do everything we can just to maintain a really chill patient before anesthesia. So after your assessment, you're going to go ahead and proceed to sedation. Venous access gives you the best control over depth of sedation, and it increases your chances of a good recovery, so we're always trying for that. This guy was getting really worked up. There was a veterinarian who was going to sedate him, and he was rearing. And it was really just the approach, because when I was quiet, and just took a minute to say hi to him, he was fine. He didn't move. So there's a lot of different types of catheters available. You can catheterize your patients, and I am more and more in the States. I don't usually internationally. Here, donkeys are fat, and when your donkey's overweight, you make it hard on veterinary professionals to gain venous access, to get a really good first stick, and it's really difficult to maintain venous access off a needle in a fat patient. So for that reason, I have started catheterizing patients here at home because more of them are overweight. When I catheterize, I do it after they're down. I don't do it while they're awake because, again, that's just a whole bunch of stimulation that, unless you're working with a really chill donkey, doesn't need to happen before they're sleeping. You can give IM drugs and anesthetize them. We don't like to do that. And I cannot remember having to do it in a donkey. You get slow uptake and clearance, so you do compromise your recovery to some extent and your anesthesia. You have to wait 20 minutes after you give it. You've got to double your dose at least. And if you're going to IM sedation, the doubling your dose would probably not get you where you need to go just because they're already excited or difficult. So you probably need to triple your dose, so then you're putting a big slug of drugs into their muscle. And again, it's not ideal for general anesthesia because it does compromise both anesthesia and recovery. This is a video of pinning a mini mule. It's a bunch of clips that were given to me. I didn't cut anything out. Well, I did. I got mad at the end, and I cut that out. But this mini mule makes it look like this was going to be easy for anyone, but someone had already tried to anesthetize him. They pinned him behind a gate where he was, and he was trying to bite me there. He'd made a couple of more serious attempts before that, and he had been swinging his leg at me. We're in a trailer, and the latch doesn't shut, but they had tried to anesthetize this mule before, and they had stuck him in the butt with something, and he had jumped 10 feet, and they had then tried to anesthetize him. They hadn't gotten his feet fully trimmed, so they must not have gotten an adequate dose. But really, as long as you don't get excited and you don't get tense, I'm not tense at any point during this. I'm not excited about any of it. I really want IV access because I really don't want to compromise my anesthesia. And as long as you have some skill with a needle and have some tools in your toolkit, I'm covering his eye. You can see when I place this needle, he doesn't move, he doesn't feel it. He doesn't care about the needle, he's worried about me. So I'm in the vein and I'm just gonna go ahead and give him his sedation, and then people get excited and it was like, stop, shut up. You're gonna ruin my anesthesia. Why are you people getting excited? Anyway, it went great, he got up great. We castrated him and trimmed his feet. It's just a matter of staying quiet and not jacking your patient up if you don't need to. So, moving on. You always need to have your patient adequately sedated before you induce them. Induction without adequate sedation is going to result in you having to chase them with anesthetics, and you don't want to have to do that. And after you sedate them, they get sedated and then everybody gets excited and starts talking and moving around. And sedated animals are really easy to rouse from sedation, so it's really important that after you sedate them, you stay quiet. And allow that sedation to work. Otherwise, you're going to have to give more, and the more you have to give unnecessarily, the more you compromise your patient. Make sure there's no hazards in the area. Make sure everyone's ready. I leave my needle in the neck after sedation. I don't pull it out. I use the same one to induce with. Occasionally, something goes wonky, it clots or comes out of the vein, and I have to re-stick, but most of the time I can use the same needle. The induction agent's given over about 10 seconds. Going too fast will cause stiff seizure-like induction. Going too slow will cause a really ugly induction as well, where they're just kind of staggering around. And you want to guide, if you can, the patient down by using their head. I have a couple of induction videos here. So your intravenous technique in a donkey is really pretty much the same as in a horse. The same good techniques that you would use in a horse work in a donkey. You just have to keep in mind that there are some anatomical differences. So they've got more valves in their neck. It's a really short neck. They've got a thicker sub-Q muscle. You want to stay in the upper third of the neck where the, I cannot say this word, omohyoideus muscle is between the vein and the artery, because it makes it just slightly harder to stick the artery. You can still do it though. You just have to practice good technique. So to make your IV injection work better, you always want to have the vein taut. If the head is down, the vein is relaxed and it's like a rubber band, it will just push away from your needle. So you want to raise the vein to get the vein taut. If you extend the head too far, so everything's kind of in a straight line. You've gone too far and you lose what you gain by raising the head. You want to fully occlude the vein. A lot of students in particular aren't taught to fully occlude the vein. And it's really important because it's, it's a garden hose if you fully occlude it. If you don't, it's hair thin. So fully occlude the vein, visualize the length of the vein so that you know what alignment you need to put your needle in. Because if you come at it sideways, you're just going to go right through. And then you can bounce or milk the vein. I don't know if that makes sense, and set your fingers on it if you're having trouble seeing it, and then you can feel where it's at. So donkeys do, of course, hair. Some particular breeds do. Some individual donkeys do. Some donkeys have really, really fine skin, and it's really easy to get your needle in. And others, like those BLM donkeys, the older ones, man, that stuff is like a 1/4 inch thick, and it's like steel. It is. So if you can't see or feel the vein, you can always clip the hair or wet it with alcohol or disinfectant. In those animals with really, really thick skin, if you want to place the catheter, I would make either an incision, or I use a 14 gauge needle to make a puncture hole. Otherwise, your catheter is just torn to bits as you're trying to get it through the skin into the vein. Okay, I've got a couple of inductions. These are in Mexico. This guy's a little twitchy, and it takes him a minute to get him down. When he goes down, he's actually on a slight incline that I either didn't notice or forgot to turn him around. He has a tough recovery. He's in one of our recovery videos too. Anyway, we're going to go here in a minute. We don't work in Mexico anymore, but these guys who we worked with in Mexico, if you can see, he's just on a slight incline there, and that was a mistake, and he had to pay for it. So this is the second induction. This is Victor at the head. This is like a 300-pound donkey, and what I induce my average 300-pound donkey in Mexico with is 5 mils of ketamine, and I give them a mil of Valium after their sedation. And that's why he's a little extra wobbly, is because he's got that bit of Valium on board. Eric and I don't go to Mexico anymore, and people used to say, what you're doing isn't sustainable. What's going to happen when you stop going? Well, Victor still does clinics in Mexico. We support him doing the work in Mexico. We have people still doing the work in Nicaragua that we support. So it is sustainable to work for years somewhere and train people. You can find the right people to keep doing your work. It's absolutely possible. So we're almost there. No, we're not. We're only halfway there. This is the slow-acting ketamine. So we'll just wait. Anyway, Victor has a whole crew that is continuing to do the same work we did in Mexico. He's still working with veterinary students. We've got videos this year from the veterinary students inducing anesthesia in these donkeys, and they're doing just as much work as we were. I mean, they're kicking butt. We're so proud of them. We think Victor will continue what we used to do in the Dakotas as well once he gets settled in his career. Again, slow-acting ketamine. There we go. So once they're down, we go ahead and get a pillow under their neck and a towel over their eye and gain venous access. And again, in Mexico, I just use a needle. They're not overweight, and it's really easy. One of the things that makes it easier is if you take your pillow, this one's a little too far forward, and put it back so that it's under the back of the jaw and most of the neck. Because what that does is it causes the nose to tip down, and that tautens the vein for you. And makes the vein stand up better, so you can see it better to use it. So we sometimes also put one of the really thick yoga mats under their shoulder and hip, depending on how hard the ground is, and then go ahead and assess your anesthetic depth. And you want to wait a couple minutes after they hit the ground to decide whether or not you need to top them off for that anesthesia to catch up with them and take full effect. At that point, you're going to monitor the depth of anesthesia and try and anticipate anesthetic flow. So if you know something painful is coming up and you think your patient might be getting a little light, you might top off ahead of that. And you need to stay in touch with the surgeon so that you know what's going on. That can be really hard. Eric wrote some notes for this, and he wrote that it was okay if you slapped your surgeon every once in a while. I did not put that in. So you're going to monitor anesthetic depth by watching the respiratory rate and depth. If they're breathing nice and even and slow, they're at a good plane. If they start taking fast, deep breaths, you know they're getting a little light. Watch for muscle stiffness, motion, vocalization. Nystagmus means they're getting light. And they generally will tear before you get the nystagmus, although it's not always true. One trip in Nicaragua, not a single patient gave me a tear once. And I don't know if that was dehydration or what, but one trip I didn't get a single tear, and that's my favorite thing to look at to decide if I need to top off. So anyway, whoops. Okay, so strategies to mitigate poor recovery. There's a whole bunch of things that can cause your recovery, that can increase the anesthetic needs of your patient and cause a poor recovery. So one of the things is I don't separate friends, and I always sedate in place. Everybody thinks their horse is going to be fine when you take it out of the trailer, or their donkey is going to be fine when you take it out of the trailer. They always get excited when you take them out and they're somewhere new and they're looking at new things, unless they're really well trained, and none of my patients are. So, I mean, they're just not. They're all under-socialized. So, I mean, except for the ones that live at home. But anyway, so I always sedate with at least light sedation in the trailer before I take them out. If I have friends together, I don't separate them. If two of them are having surgery, I decide which one's more nervous and which one's less nervous. I sedate the less nervous patient, because when I start screwing around with the more nervous patient, the less nervous patient is not going to be less nervous anymore. And I don't want them to get excited before their surgery. So I sedate the less nervous patient, and then I sedate and induce the more nervous patient. I'll have to go back and resedate the initial donkey who had sedative. That doesn't bother me a bit. We do everything we can to not fight with them and not risk exciting them, because that's the biggest factor that's going to increase anesthetic needs and increase the potential for a poor recovery. So then you want to anticipate the anesthetic needs and not chase. The worst recoveries are ones where you never quite get them to that plane of anesthesia that you wanted. And so if they're not deep enough right up front, some people say, I heard somebody say, I won't let anyone top off for 20 minutes. If I didn't get the dose right, I want them topped off. I want them anesthetized to begin with. Otherwise, you're just behind the 8 ball the whole surgery. And use appropriate pain management. This is, again, really important. If you can block or do an epidural or give nonsteroidals, if that's appropriate, do it, because you will increase the patient's anesthetic needs, which will improve your recovery quality. Potentially. You can ruin any recovery. There's so many ways to ruin a recovery. I mean, there are. Jesus. Anyway, so post-op, you want to reduce all stimulation that you can. After surgery, everybody wants to start talking, and it gets louder and louder. I try and send everyone away. Just go away. I want quiet. Leave the eye covered until they're ready to get up. If I gave more than 2 toppers, or if I feel like I didn't get them to the plane I wanted, or if I'm just unhappy for whatever reason with how anesthesia went, I give xylazine after surgery to help them sleep off their ketamine. It's a 10 to 20% of the initial dose that I gave. Again, try and keep it quiet, try and keep people still. If there's a lot of insects, use fly spray. The flies one year in the Dakotas ruined every dang recovery. God, it was horrible. That was a horrible year. And just don't disturb your patient. Let them sleep it off. I'm not in a hurry. So donkeys recover differently. In weak or geriatric or injured animals, you may want to use a tail recovery, and I've got a video coming up of that. You could also sling recover, but you have to train them ahead of time. With the tail assist recovery, you have to be careful. There are patients who will panic if you're hanging off of their tail. So, and you're not trying to lift them, you're trying to give them something to lean against. So you're just trying to keep them from somersaulting forward during recovery. If you see them getting tense, feel them getting tense, you have to let go, or you'll cause them to bolt, and then you'll start a ping pong that you don't want during recovery. The radiographs are of our donkey who will be here tomorrow, barring any problems. We've anesthetized her several times and recovered her successfully. She's super sweet. Old woman who had got a fracture in Mexico and wandered around and healed it. Rosie. So, donkeys recover differently than horses. They tend to stay sternal for quite some time before they get up. And then when they get up, they tend to be ataxic for quite some time. So it's a good idea not to rush your donkey recovery. Also, there's occasionally you'll have a donkey that does a stiff-legged thing during recovery. It's not abnormal. You don't see it in all of them, but it's relatively common. Some is cut out of this because I think this is like a 20-minute recovery. I think he's sternal for about 20 minutes before he gets up. The stiff-legged recovery, a lot of those, if you just push them up into sternal recumbency, if they were a quiet donkey to begin with, they'll stay sternal. If they were upset to begin with and you push them up into sternal recumbency, they're probably going to try and get up before they're ready. So this guy stays here for a bit, but when he gets up, it's beautiful. I probably should have edited a little more out of it. And this is Mexico. This is, where we work in Mexico, where we used to work in Mexico, where the kids still work. So that's a typical good recovery, and the majority of our recoveries look like that. We do occasionally have, whoops. Okay, so this is a head banging recovery. This is the donkey who is sitting a little bit downhill. I hate showing this, but I'm not perfect. This is years ago. I don't know if I was chasing him with anesthesia or if I just should have given him xylazine at the end. It's possible I gave him xylazine at the end and it wasn't enough. It's from so long ago that it was just going to be impossible for me to find the records, and we've been so busy. So Miguel's going to hold his nose up for a bit to keep him from trying to get up, and he will relax. Generally, they'll relax, and you can put the head down and give them some more time. And now he's at a stage where he really wanted to be sternal, so Miguel helps him up into sternal recumbens. This was an extended recovery. Again, I hate it when I have recoveries like this. They're not common, but this is an example of what you don't want in a recovery. Okay, so this is a tail-assisted recovery. This guy had a pretty good size sarcoid on his face, and so it was a longer surgery. Our castrations are really quick, but the sarcoid removal took longer. He laid here for quite a while, and I was pretty sure he was going to need help getting up. At this stage, we were not doing any more. We would freeze the sarcoid for 10 minutes in liquid nitrogen and then auto-vaccinate him, but because we've had some good success with that. But at this stage, we weren't doing that. But that wouldn't have made the surgery any shorter because you have to freeze your sarcoid for 10 minutes. He's buckling here a little bit on that right hind. We do occasionally see in donkeys who've had a leg rope on, he didn't because he wasn't castrated, but we do occasionally see, we've seen in maybe 6 or 10, a buckling that continues. He's going to take a step in a minute and be fine. And with those, we put a nice heavy bandage on the leg and leave it in place for a couple of days and then take it off and they're fine. As long as you don't allow them to walk around on their fetlock for too long after they stand up. This is the stiff-legged recovery. And just there's a certain population of donkeys that it's like they can't get themselves sternal, and so they're trying with their hind legs. So we let him do this for a few minutes. And then in a minute I'll come back and sit him up. And he'll sit sternal for a bit after that. It's not in the video, but he'll sit sternal after that quite happily. He was he's really, really wants sternal now. Come on, help me up. Okay, so anyway, he'll stay like that for a while before he stands up, and he'll stand up great. This is another protocol for field anesthesia. It's the Donkey Sanctuary's field anesthesia protocol. It's not a protocol that I would use. When I look at it, and they're working in a different population of donkeys than I am, for one. When I look at it, they're giving detomidine for sedation, and we don't recommend detomidine for anesthesia. We avoid it like the plague. But also then when they're topping off after their detomidine, for the first 30 minutes, they're topping up with just ketamine. And when I see that, I just see so much potential for that head banging recovery. I mean, like in my mind, that's what I see. Oh my God, I don't even want that recovery. So if I was forced to use this, I would finish up with xylazine at the end of surgery to help them sleep off their ketamine. And again, they're working in a different situation entirely. So I'm assuming this works for them, but I would way prefer to use their theater protocol, which is xylazine. In the end, what the safest anesthetic protocol is the one you know. So any anesthetic protocol can be appropriate if you're accustomed to it and know how those anesthesias go. So that's really, no, I think yes, there's a summary, one more slide. So, in summary, I'm gonna go over, because I only have 10 seconds left. Okay, the differences in donkeys are they metabolize ketamine more rapidly. They're more sensitive to guaifenesin, and that's really important because you can't kill them with guaifenesin. So be careful if you're using it. The basic protocol is the same. Xylazine, ketamine, adding butorphanol and benzodiazepine helps. And one of the most important pre-anesthetic managements is just keeping them quiet. That will improve your anesthesia and recovery all on its own if you can just keep the animals quiet. So anyway, hopefully someone got something out of that.
Everybody, let's give Cindy a round of applause.
Is that okay?
That's great.
Okay.